wrong with you? The doctor tells them, now, I see nothing wrong with you. The doctor tells the patient, see, by clinical examination, it has got limitations. He didn't find anything, but anyway, he advises CT scan. For example, patient comes with hyperpyrexia. If the clinician finds, except pyrexia, he doesn't find any other. And in those cases, CT of the abdomen or even lung helps to pinpoint a diagnosis. This is the CT scanner. Now, CT of the shoulder joint. Look at the cortex. It is disrupted in the articular portion near the scapula. And this is septic arthritis, or the soft tissue swelling is there. Whereas this same patient, if you go for a radiograph, you may not find it unless an astute radiologist looks carefully into the cortex. Of course, there will be soft tissue swelling, which is nondescript. Synovial chondromatosis, even plain film tells you, rounded calcifications, flaky calcifications, chondromatosis. But then people may think it's a chondrosarcoma. So whereas CT, it shows you there is no extra soft tissue. The calcifications are contained in the synovial cavity along the bursa, so it must be benign synovial chondromatosis. For example, I'll tell you, patient has got pain, say same patient. Even before the calcification occurs, you can do a CT. Even before the calcification seen on plain films, you can do a CT and you find multiple densities, which you derive that there must be chondromatous bodies, small chondromatous loose bodies. Again, CT displaying the synovial cavity, some fat component, fluid component, and then multiple calcifications of various sizes and shapes. And in the spine, cross section of the lumbar spine, one of the lumbar vertebrae, look at the small nodes. Small node is nothing but herniated disc material. Instead of going posteriorly and produce neurological disturbances, or anteriorly, it may go upwards or downwards, herniated disc, and that causes reactive new bone in the vertebral body, spongiosa. It is an indication of early degenerative joint disease. Osteoporosis may be present. So, because of the osteoporosis, the disc material may herniate up or down. Hyperparathyroidism, again due to weakening of the vertebral bodies. Scheuermann's disease in young people, sports active people, athletes, you may get a so-called Scheuermann's disease, namely, besides small nodes, you get irregularity of the apophyses of the articular margins. And of course, in certain neoplasms also, metastasis or primary, the disc may herniate because of the weakened vertebral body, the adjacent vertebrae. And again, a cross section of the cervical spine to show this is, for example, extensive calcification of posterior longitudinal ligament, which you see producing some pressure upon the spinal cord and neurological changes. This is what is called ossification of the posterior longitudinal ligament, OPLL. And then originally it was described in Japanese patients, and they used to call it Japanese disease. But now we see in, for example, in Andhra Pradesh, fluorosis, or in other areas also where fluorosis is present, we can get OPLL calcium. And fish, what is fish? Focal, idiopathic, skeletal hyperostosis. That is another entity in rheumatic disorders, particularly occurs in older people with no loss of density in the bones. That is the most important. And of course, you see the facet joint nicely, the spinal cord, the space around the spinal cord, the vertebral body, etc. Such clear picture of the vertebral body you can see in the CT. Again, another cross section of the lumbar spine. Note the thick facets, dense sclerotic facets. Facet joint is almost gone, obliterated. And look at the lumbar canal. It is a triangular space because of the hypertrophy of the ligaments and facets. The canal is narrowed. It is called lumbar canal stenosis, producing cramps, etc., other neurological symptoms. and common tuberculosis of the spine. Right, in plain films you can see, but you cannot really assess the soft tissue, and particularly the calcifications. Any paravertebral soft tissue swelling with calcifications, the first thing you think of is tuberculosis of the spine. Without that calcification, you may think, metastasis, myeloma, brucellosis, etc., anything. Destruction of vertebral body, paravertebral abscess, and multiple calcifications. Again, the left sacroiliac joint. Look at the widening as compared with the right sacroiliac joint. The joint space is widened, eroded, mild reactive scoliosis is seen. Besides everything, there is a soft tissue swelling, which the arrow points out. Although the plain film shows, but then in order to confirm, they have taken a CT. Is there any calcification? Is the soft tissue swelling overlying the sacroiliac joint, or is it associated with this? This is a psoas abscess. And then painful foot. Often people come and plain films you may not see much. This is a calcaneo-talar coalition. Sometimes a bony bridge may be seen in conventional radiographs, but cartilaginous bridge with a pseudo-arth joint formation also may be noted, and it is well defined by CT procedure. Now we come to nuclear magnetic resonance phenomenon. We used to call NMR. Now that N is anything nuclear, people are scared. So that N is removed. Now we call it MRI, magnetic resonance imaging. And then Felix Bloch, Purcell, they got Nobel Prize in physics, and Paul Lauterbur and Peter Mansfield from US and UK, they got Nobel Prize winners in medicine. They are for technical physics. Here it is in medicine in 2003 for discovery of MRI. Magnetic resonance imaging, what are the advantages? No radiation, high resolution, high contrast, non-invasive, and no untoward effects, described in terms of signal intensities. Too technical for dermatologists to understand, but even then there are what is called T1, T2 weighted images, fat suppressed images, etc. that we use, radiologist uses in order to bring out the pathology early on in the patient. MRI of the shoulder. There is a full thickness. Look at the arrows. They show full thickness rotator cuff tear. Rotator cuff tear could be acute or chronic. Chronic particularly in patients with rheumatological disorders. In osteoarthritis also you can get arthritis, rupture of the rotator cuff. Again, MRI of the shoulder. What is rotator cuff? It is a combination of supraspinous tendon, trapezius minor, and subscapular. All these tendons are inserted into the capsule and forms a cuff. The conglomeration of all these tendinous attachments to the capsule, and it's called the rotator cuff. And the rupture of this rotator cuff is not uncommon. Again, shows the signal intensity there because of the cuff. Again, see, oblique coronal, we have to take multiple images in order to demonstrate. This is just a cuff, is there a hematoma, is there a fluid? All these points can be judged by taking multiple rotational images. Again, same level, abrupt transition from the normal tendon, signal wide. Again, I have to tell you, this MRI is described in terms of high signal, low signal intensity. High signal intensity, low mixed signal intensity. High signal is generally of calcium, bone, fat, etc. Again, coming back to the rotator cuff tear, I told you the rotator cuff is formed by the attachments, tendinous attachments of supraspinatus, infraspinatus, teres major, and then subscapularis. All these tendons are inserted over the capsule and form a cuff to protect the shoulder joint. And then MRI shows any tears, acute tears with hematoma, chronic tears with synovial effusion. All these things can be seen judged by the intensity of the signals, high intensity signal, or deficiency of the defect in the intensity of the signal. There is fluid in the bursa, subacromial and subdeltoid bursae. shows the arrows. At surgery, this portion of the tendon readily disintegrated, crumbled upon probing, revealing a large defect. Again, MRI shoulder tear of the rotator cuff. Note the gap in the tendinous attachment between the tendinous gap tears. MRI shoulder, another rotator cuff tear. Several examples of the same. Another advantage of MRI, using MRI in detecting imaging methods, is transaxial, like CT, coronal, sagittal, and orthogonal. All in same sitting, you can do all these positions without shifting the patient. And multiple lesions, so the entire, for example, spine, entire spine can be detected. In fact, today, entire body can be done by MRI images. Marrow extension, marrow generally you cannot identify by regular radiography and by ultrasound, but marrow signals, anything early on marrow infiltration, maybe edema, maybe hemorrhage, it may be infiltrated, it may be leukemia, metastasis. All these can be detected very nicely by MRI because it is highly sensitive. Soft tissues, differentiation between soft tissue, calcification, ligaments, etc. And in the spine, spinal canal contents. Now, without doing any myelography, you can see the spinal cord, and in fact, you can see the roots emanating from that, the pericardial space, any defects in the meningeal space, the facet joints. All this can be identified by MRI. And virtual arthroscopy. See, today, arthroscopy is done by the orthopedic surgeons, occasionally by rheumatologists also. But virtual arthroscopy by MRI, better to outline soft tissues, muscles, whether hypertrophied or atrophied, tendons and ligaments, are they edematous or ruptured, and cartilage thickness. For example, osteoarthritis, there is atrophy. Acromegaly, there is hypertrophy. Sometimes completely cartilage is gone. So, in all these things by MRI you can see. Synovium, of course, we have said already, any effusion and any hypertrophy or any loose bodies in the synovium. So, again to repeat, to impress upon you, MRI in rheumatology, no radiation, early diagnosis of erosion, demonstrates hyaline, fibrocartilages and ligaments, tendons, tendon sheaths, synovium, muscle fibers, bone marrow involvement, I already said. This is just to stress and impress upon you the role of MRI in rheumatology. Effusions distinguishes psoriasis from rheumatoid arthritis, and edema, contusion of bones, poor in identifying cortical bone, but still you can see that is the only disadvantage as compared with CT. Cortical bone and calcifications are less sensitive by MRI, more sensitive by CT. And then by signals, so earlier by intensities, and then tissue. Sometimes we use contrast, gadolinium, DTPA. And as I said earlier, T1 weighted images, T2 weighted images. These are all the signals that you get. Low concentration, very bright, T2 bright, like that. With reference to CSF, all these signals are made. And cervical spine, 64-year-old male. A case of rheumatoid arthritis with atlantoaxial dislocation. Subtle, and then you don't want to shift the patient or move the patient to see how much subluxation is there. It will be dangerous and sometimes may precipitate quadriplegia. So, without shifting, without altering the position of the patient's neck and head, you can do MRI and nicely outline not only dislocation, how much of it is compressing. The almost strangulation in the spinal cord. So, all these things you can find by MRI. Psoas abscess and plain films you may not be able to see, nicely showing the signal intensity changes. Lumbar canal stenosis, I showed you in the CT cross-section area. Same thing, the multiple disc bulges you could see in the sagittal plane, encroaching upon the spinal cord. Scalloping. Tuberculous arthritis, 45-year-old male, for example, sagittal T1 image with pain in the left ankle, and then you see the signal intensity and an abscess formation, also indicating that is fluid accumulation. A proven case of tuberculous bursitis of the ankle joint. Not many changes in the bone, but all in the bursa, confined to the bursa. Again, to go back, T2 weighted images, note the normal shoulder, the high signal intensity in the bone, acromion, head of the humerus, and fat high intensity. Again, to show oblique coronal view, musculotendinous junction, supraspinatus tendon shows abrupt change, indicating, again another case, 30-year-old male with history of right shoulder pain. Look at the T2 images, erosion, synovial thickening, and fluid around bicipital tendon, inferiorly, you could see, on you, in the film on your right hand, and the image on your right hand side. 80-year-old male with history of swelling of left shoulder. We have seen already this. I have showed you a case with bursitis and rheumatoid arthritis with rice bodies. Here also is a tuberculous bursitis, low signal on T1W and T2W sequences, in contrast to high signal. See, in pigment, the differential diagnosis is pigmented villonodular synovitis. There's also you can get a high signal, whereas here subacromial and subdeltoid bursitis is, they call it melanocyte bodies. There rheumatoid arthritis we call rice bodies. Beautiful description. Again, tuberculous bursitis, what is the differential diagnosis? Rheumatoid arthritis, osteochondromatosis, and pigmented villonodular synovitis. Occasionally, amyloidosis also may give high signal intensity. T2 image showing synovial thickening with axillary lymphadenopathy. You don't have to do a lymphangiogram. Even MRI shows the axillary lymphadenopathy. Again, another tuberculous arthritis of the shoulder, 30-year-old male, right shoulder, radiograph only showed osteoporosis. Here you could see again lymphadenopathy. Another tuberculous arthritis. Cartilage lesions are common in young and middle-aged patients with femoroacetabular impingement or labral abnormalities. Earlier, remember I told you on arthrography, the labral abnormality. Here, without doing in a conventional arthrography, we can outline, most frequently found in the anterosuperior portion of the acetabulum. The arrows show. T1 images intracapsular hemorrhage, nicely seen with the arrow points out. In T2 intracapsular effusion, arrow points out. Gadolinium contrast, occasionally we use osteonecrosis plus joint effusion, of course associated with synovitis rather than effusion. The differentiation between these two by the intensity of the signals. Septic arthritis, plain film shows marked erosion, but the question was it the osteonecrosis of the head, urosophageal, idiopathic osteonecrosis, or is it due to septic arthritis? We couldn't decide on a plain film, although there is some osteoporosis indicating must be infection, as against just pure and simple idiopathic osteonecrosis. Here, MR, after gadolinium, inflamed synovium with fluid, nicely outlined by arrows. That's the advantage of doing MRI. Again, ultrasound cannot differentiate between fluid and synovial thickening. Both are mildly echogenic, whereas CT with inflammation but no fluid. And this plain film with marked resorption of the head and neck with dislocation of the trochanter, hydatidosis, cystic lesions in iliac bone and head and neck of femur with a pathological fracture, nicely outlined by MRI. Patient on steroid therapy, obviously osteonecrosis of the left femoral head. But in order to stage the osteonecrosis, the degree of osteonecrosis, MRI is useful. Not only that, MRI is more sensitive to early osteonecrosis, in fact, better than radionuclide scan. Earlier we used to say plain radionuclide scanning is much better than plain radiographs. But today we know MRI is more sensitive than radionuclide scan. Not only that, asymptomatic patients, you do MRI. On the contralateral side also we can find early osteonecrosis. Bilateral osteonecrosis on the plain film and the degree of necrosis on MRI. On cross-sectional films also you could see the degree of osteonecrosis. Again, to repeat, MRI advantages: transaxial, coronal images, sagittal, non-orthogonal. Particular advantages: no radiation. Few examples of avascular necrosis, both femoral heads. Flow chart. Patient comes with pain in the hip. Clinically, you don't know whether it's inflammation or in older age group, metastasis or minor. Then plain film is positive. If it is positive, you do CT in order to evaluate stage and then advocate therapy. If the plain film is negative, earlier we used to do radionuclide scan if it is available. If it is positive, of course, therapy. If it is negative, even then you are not sure, MRI. MRI is positive, institute proper therapy. Menisci, look at the menisci in the knee, in the sagittal plane, posterior and medial menisci, and the tears, osteochondritis dissecans of medial femoral condyle, and plain films you may not see much. Here you could see. Ruptured quadriceps in lupus erythematosus. Look at the gap between the proximal and distal segment. Ruptured tendinochilus in SLE on your right side. You can see in the systemic lupus erythematosus. Ruptures of the tendon are not uncommon in systemic lupus erythematosus. Early osteomyelitis. The clinician or orthopedic surgeon or rheumatologist says, I don't know, there is pain in the heel, but what is it due to? See, early osteomyelitis. Bone edema in the calcaneo. The terms bone edema and contusion have come into vogue only after the advent of MRI. Earlier, pathologically we know, but on radiographic images we couldn't say it was the edema or hemorrhage. Now the nuclear medicine comes into picture. Poor anatomical definition as compared with CT or MRI, but highly sensitive. Any pain, prefer for a nuclear scan, because if it is a just hysterical pain or real organic pain, if it is real organic pain, where is the location, anatomical location? Highly sensitive but not specific. You can screen the entire skeleton, total skeletal scan you can do 100%. The tracer principle, first FSC, 1946, he got a Nobel Prize too. All these are pioneers in imaging. That's why you can't forget these people. In order to remember them and respect them, I used to give the names. Radionuclide imaging in 1950 it started. Radiopharmaceuticals in conjunction with gamma rays. Poor anatomical definition, as I said already, but good for physiology and chemistry, which on radiographs or CT, you can't study the physiology that well. Single photon emission computer tomography, otherwise called SPECT, 19 technetium or iodine I-131. And then today, PET scanning with FDG. Arthritis, what are the indications for isotope study? To know the activity. I said it is very highly sensitive. If there is increased uptake, you know it is very active. Extent, anatomical extent, distribution, how much has distributed in various tissues. And of course, today we institute therapy also, particularly in the synovial cavity, in order to prevent recurrent synovial effusion and what is called radionuclide synovectomy they are doing today. Activity in soft tissues, for example, calcific tendinitis, cellulitis, injection site, myositis ossificans, operative site may be active. That should not be mistaken. Pathology. I said already about SPECT, it improves spatial resolution. It's like a tomogram. Sickle cell anemia with the osteonecrosis of talus that you see on plain film and activity, whereas here the toe may not be so sensitive, here on radioactive sensitivity of the toes and part of the calcaneo. Bilateral osteonecrosis of femoral heads, I said already, there is a cold spot early on in osteonecrosis on the right side of the hip. On the left side of the hip, there is a hot spot which is late already. That means reactive bone has already occurred. That's why it is hot. Psoriasis, plain films may show some changes, but radionuclide scan definitely shows the distribution. From the radionuclide scan, you can definitely say it is not degenerative arthritis, it is not rheumatoid arthritis, it is definitely psoriasis. That's how we can pinpoint the diagnosis. Septic arthritis, plain films, nothing on the wrist. And a 9-year-old boy, plain films, there is nothing. Patient complains of pain, soft tissue swelling, highly active, radioactive. Multifocal infection, not only in the hands, wrist bones, and radius ulna in the ankle. As I have already said, radionuclides for radiosynoarthritis, synovectomy, Vitrium 90 for large joints, Rhenium 186 for small joints, Erbium 169, beta-emitting radionuclides, that's the principle that will kill the synovium. Again, restoration of synovia by radionuclides, local therapy for rheumatoid, hemophilia, PVNS, pigmented villonodular synovitis, or arthrosis, to inhibit the synovial proliferation. Now we come to PET scan. Everybody's PET today, positron emission tomography. Even the patients ask sometimes, sir, can I get PET scanning? Because they are so fascinated by the modern imaging method. Cyclotron is necessary. It costs about 10 crores. Cyclotron plus PET. Short-lived positron emitters, oxygen, nitrogen, carbon, fluorine. Lymph node biopsy for unknown primary. They took a lymph node biopsy. They said it is a metastasis. But then you can use PET scan. See, you can detect a small primary in the right lung, a small cell carcinoma. That's the advantage of PET scanning. And then also the anatomical, you see today it's not PET scanning, PET CT, because on PET scanning it may be hard, particularly in the bones. But which part? Is it vertebral body? Is it the pedicle? Is it the lamina? Here, PET CT indicates that it must be pedicle, and that helps us. So if pedicle is involved, it must be metastases rather than myeloma or other disorders. Vascular and interventional radiology. You need certain instruments, contrast substances, catheters, balloons, but a very little role in arthritis, except for biopsies, etc. So that's the entire picture of the recent, not so recent advances in rheumatology, other than conventional images.